Welcome to my presentation. The key topic I will be focusing on for this presentation is the bioethical issue of in vitro fertilisation, known as IVF for older women. There are considerable bioethical issues in relation to IVF. However, the scope of this presentation will be quite narrow and will not explore all of these issues. As explained by IVF Australia, the single most important factor influencing a woman's chance of conceiving is her age. At the age of 41, a woman's chance of conceiving naturally is just 4%. According to IVF Australia, if a woman is aged between 36 and 40, her chance of falling pregnant with IVF is 35%, compared to 10% if trying to conceive naturally. Since the birth of the first IVF baby in 1978, the technique has earned its reputation as a major medical breakthrough of the 20th century. IVF was originally developed for women with tubal disease, but its indications soon began to grow. In recent years, IVF has been applied to a range of subfertility, such as mild male subfertility, endometriosis, and unexplained subfertility. The birth of many healthy children has enhanced provider and patient confidence in the safety of IVF. Extensive literature is available on the subject of IVF for older women. However, I have chosen to focus primarily on the cost implications, complications, and the ability of older women to raise a child. Arguments for and against IVF in older women have been identified and will be analysed and discussed throughout this presentation. Many different arguments have been put forward regarding the use of IVF for older women. There are multiple arguments in relation to the cost implications of IVF treatment for women aged over 40 years. President of the Fertility Society of Australia, Michael Chapman, has explored this topic extensively. His research has found that if all the costs for IVF treatment for women aged over 40 were added together and then divided by the number of babies born, the cost would be $100,000 per baby. This can be compared to the cost of $28,000 for babies born to women aged 30 years. More alarmingly, the cost for women aged over 45 years was $200,000 per baby. In contrast to this, one interesting Swedish study looked at the long-term physical implications of subsidising IVF. The study explored this topic from a lifetime tax perspective, through applying generational accounting techniques to evaluate the long-term financial impact of an IVF child conceived from government-subsidised IVF treatments in Sweden. Their results indicated that when a longer time horizon is utilised and a broader range of costs and benefits, such as tax contributions, are used to evaluate IVF treatment costs, the economic benefits to the government exceed the cost required to conceive a single child from IVF. While I was unable to identify any similar studies in Australia, this would suggest that the barriers which prevent people from accessing available assisted reproductive techniques could represent a financial loss to the government that could be generated through lifetime tax contributions in the future. Literature has shown that many doctors worry about the high rates of complications with pregnancy in older women. Older mothers do have higher rates of a number of medical problems during pregnancy, including high blood pressure, diabetes, and premature labour. However, most won't. One study found that 80% of women aged over 45 have no major medical problems during pregnancy, and more than 80% gave birth at full term. There are good reasons for women to be aware of the aforementioned risks of complication and to take them into account when making decisions. But for women without major health problems, it has been shown that the risks of pregnancy are not so high that they can't go ahead. As well as this, the National Fertility Treatment Guidelines in the UK justify not providing NHS-funded IVF treatment to women aged over 42 because of a low success rate. For example, they quote that the live birth rate following IVF in women over the age of 44 is only 2%. Yet these success rates are based on IVF treatment with the woman's own eggs. For women who receive donor eggs, the chances of live birth are based on the donor's age, not that of the recipients. Where the egg donor is young, older women have relatively the same chances of success with IVF as younger women. Donor eggs also avoid the increased risk of chromosomal problems in the baby, such as Down syndrome, that are seen in older mothers. As discussed by Jennifer Jackson, an older woman is more likely to die during childbirth or before the child has grown up. This is a misfortune for the child, but many children who lose their mothers are still brought up in an acceptable, nurturing environment. The question needs to be asked: are the interests of this potential child better served if they are born to these parents, or if they never existed at all? As has been argued throughout the literature, while it is better to have a mother who doesn't die while one is still a child, it is not to say that one would have been better off never to have existed than suffer such a loss. It is important to explore IVF in older women in relation to the 4 bioethical principles proposed by Beauchamp and Childress. Respect for personal autonomy can be viewed from multiple perspectives, depending on whether the woman is using her own frozen eggs or donor eggs. If using donor eggs, for example, Niska argues that IVF is not ethically valid because IVF takes away respect for the person donating the eggs. Niska believed that there may be an underlying bond by the woman whose eggs are donated, or a grieving process for the eggs that die during IVF. While there is no guarantee that IVF will produce a healthy child, I would argue that IVF is often used as a last resort when other medical interventions have failed. I would then suggest that the benefit would outweigh the aforementioned risks. Furthermore, in regards to autonomy, it has been suggested that any restrictions on an individual's reproductive freedom should be challenged. As suggested by English, there should be no restrictions on treatment provided patients are properly informed and are willing to take on any risks. It can be argued that an arbitrary age limit for IVF would be considered discriminatory and biased. It is a legitimate concern that a child will suffer if its parents die while it is young, and older mothers are quite obviously more likely to die sooner than a younger woman. However, there are a number of convincing reasons why this objection is insufficient. To prevent older women conceiving, for example, it is inherently unjust to restrict access to IVF for women when we do not restrain older men from procreating. Furthermore, it is not certain that all younger women will outlive all older women. Age is only one risk factor that affects the likelihood of death, but there are plenty of others, such as use of illicit substances and dangerous jobs. If we do not discriminate based on the other risks, it is unjust to discriminate on the basis of age only. When exploring the principle of beneficence in this context, literature has raised the point that older women are less physically able to be parents. For example, if a woman becomes a mother at 55, it is suggested that at the age of 70, the woman will not be capable to deal emotionally or physically with the demands of a teenager. While there may be some merit in this view, specifically in relation to beneficence, benefits may also be derived from being an older parent. Perhaps children of older parents do miss out on some things that younger parents can provide, such as being able to play sport with them or taking them on adventurous trips. However, we could equally argue that older parents can provide greater financial stability and the benefit of more life experience to pass on to their children. Non-maleficence is the ability to do no harm. Literature has shown that IVF is capable of producing multiple births, which increase medical complications and costs. The older the patient population, the greater the risk of complications during pregnancy and delivery. Women who conceive when they are over the age of 40 are at an increased risk for chromosomal abnormalities, spontaneous abortion, and stillbirth. In addition to this, multiple births are associated with an increased rate of neonatal complications, longer length of stay, and the need for follow-up care. However, with all this being said, a woman choosing to seek IVF, once informed of the risks and knowing of her own desires about having a child, is the best place to judge whether or not to take on these risks. As can be seen through the differing views put forward throughout this presentation, there are arguments both for and against the use of IVF in older women. In regards to bioethical principles, the information I have read would lead me to believe that applying a sweeping policy to ban a woman from utilising IVF purely because of her age would not be ethical. While individual circumstances need to be taken into consideration, if a woman is well informed of all potential risks, it would be unjust and therefore unethical not to allow her to go down this path. While there is a reasonably strong argument that advocates that an older woman is unable to care for a child, whether it be through an inability to provide a nurturing environment or inability to care for the child physically, there are equally as strong arguments that suggest women are better equipped to provide for the child financially, and the child will benefit from their mother's increased life experiences. I think it is clear through the research I have put forward that I would recommend taking into consideration all individual circumstances. When considering bioethical issues and principles, it would not be ethical to refuse a woman IVF using age as the only indicator. From the research discussed throughout this presentation, it is my opinion that we do not have the right to restrict a specific population from achieving their highest biological potential. People should have access to desired children conceived naturally or produced through technology, and IVF offers this opportunity. I believe all women should have a right to IVF, with age not becoming a barrier to making this happen. In conclusion, I would like to ask you 2 questions to more broadly stimulate your thoughts around IVF in older women. Is this type of biotechnology being applied for the right reasons and to the right population groups? And should there be restrictions on Medicare access to IVF subsidies for older women? Thank you for listening.